Today's speaker is Kira Capalucci, who is a project administrator here at the American Medical Association. In this role, Kira manages our assessment operations and health system engagement as part of the practice transformation team. Prior to joining the AMA, Kira spent 5 years at the National Academy of Medicine, where she helped develop and launch the Action Collaborative on Clinician Wellbeing and Resilience, a national consortium of more than 100 cross-disciplinary organizations committed to reducing clinician burnout. Today, Kira will be presenting Healthcare Wellbeing and Burnout during COVID-19, findings from a national survey. Welcome, Kira. We're so lucky to have you join us today. With that all said, I'm going to pass it on to you.
Great. Thank you, Brittany. Thank you for that introduction, and good morning, everyone. Thank you for joining us. I'm excited to share with you today some of what we've been doing at the AMA over the last year as it relates to clinician well-being. So I'm going to be spending some of the time that we have today sharing some of the high-level findings from our national COVID well-being survey. And I'll also then share with you some of the lessons that we've learned in working with over 100 organizations this past year and the solutions that they've put into place to support workforce well-being and reducing burnout. So just a little bit of background. Prior to COVID-19, the AMA has been working for several years now to provide burnout assessments to organizations across the country and really serving as advisors to health systems who are wanting to build out strategy and support for wellness and burnout. So when COVID became our reality last year, we developed a new assessment tool so that health systems could monitor in real time the impact that COVID-19 was having on their workforce and then adjust strategies and support accordingly. So that became what is now our Coping with COVID-19 for Caregivers survey. This is a 20-question tool to assess things like stress, fear of exposure, self-reported anxiety and depression, burnout, but also to capture solutions for health systems to enact. We opened the survey up to any organization that was interested in using it. It was not contingent on AMA membership, and it is a no-cost survey. So organizations could simply sign up to use the survey. They received a unique URL for their organization to collect responses on their survey, and then we provided a reporting dashboard for each organization so that they could review their results. The results that I'm sharing with you today represent the responses we received in aggregate from over 85 organizations that represent more than 200 hospitals or practices from around the country. These data were captured between early April of 2020 through the end of 2020. So the data that I'm sharing today is 2020 specific. We are continuing to deploy this survey and do have 2021 data, but that's not yet ready for us to share. So we'll be looking at 2020 data in aggregate, just under 60,000 responses nationwide from about 29 different states. And the one thing I'll share on the front end is that we developed this survey to be deployed to both clinical and non-clinical staff. So we did not dictate what organizations did in terms of deployment. They could choose to just give it to their medical staff, but I would say most organizations decided to deploy the survey to everyone, so both clinical and non-clinical staff, and we have data that we'll look at today on both of those groups. So a quick note on demographics, you can see who makes up our convenience sample. The majority of the respondents were female. They comprised about 70% of our sample, and the majority of our respondents identified as white or Caucasian. That was about 64% of our sample, and 13% who preferred not to answer. As I said, we also surveyed non-clinical staff as well. So we asked individuals for their role type in the survey. So that's what you're seeing on the left chart here. About a third of our sample comes from physicians, 20% came from nursing, and then 17% of our sample comes from non-clinical support staff. We grouped all non-clinical roles into this category, so almost 1 in 5 came from non-clinical support staff in our sample. We also asked respondents to tell us which practice setting they were working in. This was a multi-select question since we know that individuals work across many settings, so respondents could choose multiple settings that they are in. The majority of our sample are those that were hospital-based, but were not working in the ER ICU, and we used the ER ICU as a proxy measure for caring for COVID patients over the last year. And 35% of our sample came from ambulatory-based respondents who were doing non-COVID care. So the majority of our sample, or 70%, are people who were likely not caring for COVID patients over the past year. So I'm going to share some of our high-level findings. This is certainly not a comprehensive report today, but hopefully will give you a bit of a flavor of the trends that we've seen emerge in our data over the past year. So firstly, looking at burnout. We use the validated single item burnout measure. This has been validated against the Maslow burnout inventory and asks respondents to rate their burnout based on their own definition. We characterize burnout as anything you see in the red, orange, or yellow. So those that are beginning to burn out and have at least one symptom of burnout, all the way to those who are completely burned out and may be at a point where they need to seek help. 49% of all of our respondents indicated burnout. This was highest in nurses at 56%, which you're seeing wrapped around in red there. But the bottom bar here at the overall scores, 49% of respondents indicated burnout. We've been doing burnout assessments at the AMA for a while, even prior to COVID. Most of those assessments focused on physicians, and in those pre-COVID data, around 50% of physicians were experiencing burnout. In our COVID sample, it's also 50% of physicians. So we aren't necessarily seeing spikes in burnout over the past year. This is also true of self-reported anxiety and depression, but that doesn't mean that it won't get worse. We know from SARS that we started to see spikes in burnout after about a year after the initial threat of the outbreak had subsided. So we'll be keeping a close eye on burnout, especially in the next 6 months to a year. And I would also say that 50% of people being burned out, that's half of our workforce. We need to be paying attention to that. Burnout is costly. People are leaving organizations or may leave organizations. So 50% is a pretty high number, even if it's not spiking after COVID. We also looked at burnout by practice setting. So again, we looked at 4 practice settings. The first 2 lines that you're seeing there are ambulatory-based respondents. The first line is those that were non-COVID care. The second line are those that were doing COVID care. And then we also looked at individuals who were in hospital-based roles, either in non-ER ICU or working in the ER or ICU. Burnout was highest in ambulatory COVID care respondents, so those working in ambulatory settings providing COVID care, as well as those that were in the ER ICU. Both were 5 percentage points higher than non-ER, non-ICU, and non-COVID care in an ambulatory setting, and I think speaks to the unique needs that we may see of the people who did provide care for COVID patients over the past year and the additional stressors that they faced beyond, sort of traditional stressors that the workforce is facing overall. Self-reported anxiety and depression. This was a self-reported measure. This was not a diagnostic measure, so there's something to note on the front end. But a little over 1/3 of all respondents noted self-reported anxiety, depression, moderately or to a great extent. This was again highest in nurses at 44%, followed by clinical support staff, which is where we categorize medical assistants and nursing assistants at 43%. So nurses and clinical support staff were experiencing the highest levels of self-reported anxiety or depression. This is another area that we'll be keeping a close eye on in our data over the next 6 to 12 months, especially as things sort of reset. COVID cases drop, but people may be left with the trauma and the stress of this past year, and whether we see these numbers climb, stay stable, or decrease over time. A lot of organizations have made mental health support services available throughout the past year and are also working to make these support services available long-term and trying to build strategies to do that now. Fear of exposure. We asked individuals whether they worry about exposing themselves and their family to COVID-19. Over 60% of respondents overall noted that they worry about exposing themselves and their family to COVID-19, either moderately or to a great extent. This is starting to come down in our 2021 data, which is great news. Obviously, we have vaccines rolling out, cases are dropping across the country. And yet fear of exposure was high throughout the year of 2020, and we saw a spike in that in the December timeframe when we started to see cases increase nationally, and sort of thinking about the extra stress that was adding to clinicians who were having to think about whether they should go home, and if they go home, how they make sure that they don't expose their family to that, and just being another level of stress over the past year. And then lastly, we asked about work overload, and this was specific to COVID-19. So asking respondents whether the impact of COVID-19 was causing them to experience work overload. 40% of respondents overall indicated that they were experiencing work overload due to the impact of COVID-19. This was highest in clinical support staff at 50%, as well as nurses at 47%. Anecdotally, I can share that adjusting to a telehealth world was tough for many, especially clinical support staff, in supporting new workflows, figuring out technology, et cetera. So we saw that come through in a lot of our qualitative data as well. And this is not to suggest that others are not experiencing work overload. This was specific for COVID, but we know that work overload is quite high in healthcare overall and is likely adding to burnout. We also asked respondents about whether they feel valued by their organization, and also whether they have an increased sense of meaning and purpose due to being part of the COVID-19 response. 46% of all respondents felt valued by their organization. So less than half of respondents said that they felt valued by their organization, which I think was shocking to a lot of groups. And then 46% of all respondents felt an increased sense of meaning and purpose due to being a part of the COVID-19 response. Feelings of value were lowest in clinical support staff at 37%, and then nurses at 40%, and having an enhanced sense of meaning and purpose was lowest in our physician population at 38%. Again, anecdotally, organizations receiving this information about feeling valued and knowing that half of their workforce does not feel valued by the organization was often very shocking to them. And yet it also provided a lot of low-hanging fruit opportunities for groups to think about how they are messaging, how they are rounding, how visible leadership is. Simple things like writing thank you notes and really acknowledging the sacrifices and the time that people are spending and contributing both to the healthcare system overall, as well as to society in general, and trying to hone those messages. We found in our analysis that having a higher sense of meaning and purpose and having a higher sense of feeling valued by your organization did serve as protective factors over the past year. So individuals who felt valued by their organization and had an increased sense of meaning and purpose also were less likely to be experiencing burnout and then self-reported anxiety or depression. And just some additional insights, we also asked respondents what the likelihood was of them reducing their clinical hours in the next 12 months or leaving their current practice in the next 2 years. We know from research, from prior research, that when individuals indicate that they may leave practice in the next 2 years, they often do leave practice in the next 2 years, which of course is something that organizations should be considering for things like succession planning, early retirements, and the cost that's associated with that, as well as thinking more broadly at a 50,000-foot view about what that means for the workforce overall. We know with SARS, from SARS data out of Canada, that people did start leaving the workforce about a year after the initial outbreak started. So we are keeping a close eye on these data as well. In our data, about 30% of respondents noted either a moderate, likely, or definite chance of reducing clinical hours in the next 12 months or leaving their practice in the next 2 years. This was highest again in nurses at 40%. Followed by advanced practice providers, which we characterize as physician assistants, and nurse practitioners at 32%. So I'm going to pivot now and talk a little bit about what we've seen organizations do in response to the data that they've received through this survey, as well as just thinking more globally or nationally with the data that we have. The term crisis can mean one of two things. It can mean an unstable situation, period of danger or uncertainty, and it can also mean a turning point or really an opportunity. And so we've been really trying to focus our work in thinking about the crisis that has been COVID as an opportunity for us to reset healthcare and to really be thinking about how we can support the workforce going forward so that they can thrive, so that people aren't leaving the workforce, and so we can ensure that burnout rates don't climb. We know that COVID has both created new issues and stressors in the workforce. It has exacerbated issues that existed long before the pandemic hit us. But COVID's also created an opportunity for us to reconsider, this moment as one in which we can transform the way that we operate to better understand what removes joy in work, but also what gives it back. Some of these changes that we've seen will focus on individual resiliency and helping people connect to what resiliency means to them. But it's also certainly a time for us to re-examine our operations and our team structures, our communications, and our cultures so that we can support the well-being of everyone in healthcare. Because if we care about patient safety, and if we care about quality of care, and if we care about costs, we have to care about the well-being of our workforce. And so we're at a crossroads. As I've mentioned, we know from the SARS epidemic that it wasn't until about a year after the initial threat of the outbreak subsided that we started to see an increase in depression and mental health concerns, as well as burnout. It was also about a year after the initial threat of the outbreak before people started leaving the workforce altogether. So the adrenaline, if you will, of that year sort of began to subside, and there were some major issues left unaddressed. And so we can learn from past events like SARS. That is one of the reasons why we made this survey available, so that we could be collecting data early, so that organizations would be equipped with those data to make changes and really be responding proactively to ensure that there are supports in place to address mental health concerns, burnout, and really the general reset of operations. We know that short-term stress and crisis can lead to long-term stress injury. But we also know that short-term stress can turn into post-traumatic growth or thriving. So this is our opportunity to transform the way we think about well-being of the workforce and to really invest in wellness so that our workforce can thrive and choose to stay in the workforce, which ultimately benefits everyone. So really trying to reframe wellness is not just something that we do or something that we need to solve, but rather that it should be a core institutional value that is then demonstrated by the institutional decisions that we make, including our investments. So what would help? We asked a question on our survey about 3 supportive resources to understand whether those items would support and help individuals during this time. The first was administrative support, so thinking about whether there's support for responding to inbox messages and just generally managing an inbox that can be pretty unwieldy with patient portals, helping with documentation and things like order entry. 2/3 of ambulatory respondents noted that this would be helpful to them. This was highest in general internal medicine and family medicine, which if you are part of one of those specialties, this is likely not surprising to you at all. So we've been thinking about things like team-based care with in-room support, training up medical assistants, if it's allowed in your state, to help them handle things like inbox messaging and documentation. Our Steps Forward website, which Brittany mentioned at the start of today's webinar, and I believe will be mentioned at the end as well, has a plethora of modules to really help organizations think about small interventions, especially in primary care, that can help support in the administrative burdens. Administrative burdens are not unique to COVID. We know from all of the data we have pre-COVID that administrative burdens are a major driver of burnout, especially when thinking about the time outside of work that physicians spend specifically on the EHR outside of their normal work hours, and that being a major correlate to burnout. We also asked individuals whether having healthy food easily available would be helpful to them. This was rated highest as a helpful intervention for people that were working in an ER ICU setting. This is certainly not something that's going to solve burnout, and yet over the past year, we've seen a lot of organizations pivot to finding small ways to make sure that their physicians, their care teams, even their non-clinical staff have one less thing to think about. So either having food delivered, if they were able to do that, that was very popular early on in the early days of COVID. But also still now we have groups who have been able to put programs in place where the cafeteria of the hospital has to-go meals for dinner, so that individuals, again, just one less thing for them to think about. In our qualitative data, we've had a lot of respondents ask for concierge type services, like having dry cleaning available and those types of things. So again, certainly not a cure-all to burnout, but maybe some low-hanging fruit opportunities for organizations to consider if you are not yet doing work around wellness. And lastly, personal access to mental health care. 66% of all respondents noted that having access to personal access to mental health care would be supportive of them during this time. We've seen a lot of groups put supportive resources in place around mental health care, whether that's temporary counseling services being available or peer support groups, or even having just resources available for individuals to have support for their mental health. I will say the one thing that we've discovered, especially in groups who were putting counseling services, sort of drop-in hours available throughout the pandemic, making sure that we aren't forgetting about third shift. That was kind of a lesson for us to learn. We had a lot of groups that made those services available early on to first and second shift, and third shift in their surveys would tell us, this is great that it's available, it's not available to us. And so those were some easy fixes for organizations to make and weren't necessarily thinking about that when they first put them in place. So overall, over the past year, there's about 5 different themes that have emerged in terms of organizational solutions and actions that they've taken in response to the data that they have. Many of these themes were true of COVID times, but can certainly be true in non-COVID times. So first, thinking about things like basic needs. Again, as I shared about having healthy food available, in the first month or two of the pandemic, this is where a lot of the wellness efforts were focused in thinking about personal and family safety. So having explanations for how people can safely go home to their families and not expose their families, since that fear of exposure was so high in the early days. Thinking about food, transportation, and lodging. So a lot of organizations focused on meeting those basic needs early on in the pandemic and are still to some degree thinking about that now. Leadership and communications, obviously very important in a pandemic, but certainly important beyond a pandemic as well. So streamlining communications as much as possible. I think many of you can likely relate to the early days of the pandemic where you may have been receiving communications from your department chair, your unit leader, your CEO, and HR, and it being a lot to sift through and not really knowing who you should be getting communications for. So really figuring out who people want to hear from, which varies by organization. Some groups want to hear just from their CEO, some groups only want to hear from their department chairs, but figuring that out and then streamlining communications, as much as possible, and acknowledging that there are a lot of communications that people were trying to understand in a very hectic time. We had organizations create checklists for leaders around how to be transparent and clear in communications, and really acknowledging the uncertainty in those communications, and really how to normalize the wide range of emotions that were happening and being a visible presence in rounding. So aside from sending communications out, doing rounds and asking very simple questions like, what do you need and how can I help you? And that's often a good starting point if you're not ready to collect, a massive amount of data, but just getting out there and asking people how you can help them. The next theme was really around reflection and processing and peer support. Peer support has become infinitely more popular this year than we were used to seeing. I think almost every group we work with has at least some kind of formal or informal peer support program. So really making opportunities available for people to have shared experiences and talk about what they've gone through over this past year, but certainly would extend beyond COVID and just having colleagues to support. We work with a organization called Peer RX Med. We're happy to send that out after today's webinar. This is a free service. It's led by Dr. Mark Grunewald at the Carilion Clinic in Virginia. And it's a way for individuals as buddies to pair up and sign up to receive communications from the program with prompts for these peer support connections. And you can sign up for whether you want prompts, weekly or monthly, but it really gives folks an opportunity to have a starting point for where those conversations can start if they're not really sure how to access those conversations with their peers. Of course, other organizations have developed more formal battle buddy or peer support programs, and there's a lot of literature out there right now. And then the last two categories, so normalizing health seeking and making access easy. It's hard enough to know when you need help or that you need help, and to figure out how to get it is another burden. So making sure that there is really accessible information about what's available to your employees around mental health. A lot of groups did this through just having an intranet site just one page where people could go to find out what options were available to them, or even just a flyer that's been posted in, in bathrooms even, but just really short and sweet and to the point of what options are available to them, whether that's short-term therapy connections, group counseling sessions, or, peer support, or even just, things that they can do on their own. Obviously, everyone seeks help in a different way, so making a diverse array of opportunities available to them, and then making it really accessible and clear for how they can access that was important. And we encouraged organizations in their communications about the survey to share any resources that were available, so that it wasn't just, here's a survey, tell us how you feel, but here's a survey, if you need help, you're not alone, here's what we have available to you. And then lastly, around measuring and sharing those results transparently throughout your organization. We would say you can't fix what you don't measure. And so having data to really inform decision making has been really important for the organizations we worked with pre-COVID, and will certainly continue to be important post-COVID. And we really encourage organizations to not only collect those data, but to share them transparently. We would see comments in our surveys about, well, I'm giving you this information and then I'm never going to hear about it again. So organizations taking the effort to hold a town hall or to somehow share some of those data so that people know that the organization has seen and heard them, and also what potential follow-up steps might be, so they feel like their responses aren't going to waste. If you are not able to yet do a full formal survey, focus groups are a great option. And again, as leaders, just rounding and asking those basic questions, like how can I help and what do you need, can be another way of just collecting those data. So I would just end, if you come away with one message from today's presentation, it really would be the opportunity that we have. We really think about this right now as the glass is half full. We have more people than ever thinking about well-being, coming to the table to do this work. So it's exciting. And I think we do have an opportunity here to keep expanding this work. And as we go back to normal, how can we expect people to go back to the way that things were? We can't, and we shouldn't. And so we really do need to reconsider our processes, our expectations, so that job demands ultimately meet job resources. We work closely with a large system out of the Boston region, and they shared with us that their mental model for this work that they've adopted is one of subtraction, not addition. So really focusing on streamlining workflows, meeting people where they're at, changing expectations about what it means to work in healthcare, and that we're not superhumans that have no emotions, but in fact, those emotions are very real and need to be acknowledged and honored if we want to transform the systems that people are working within. And as I've shared, more groups than ever have come to the table to do this work. It's kind of hard to describe to you how many more groups just we at the AMA are working with now compared to 12 months ago. So there's attention on this issue. Leaders are seeing that an investment is needed for this work right now. And so this is a moment for us to capture and lead from. And I would just leave you with the notion that there is no single silver bullet for this work. We have to be more curious than that, and we have to listen better than that. The cultures we all work in are different, and so some of the things that I've shared with you today may make sense for your organization, and they may not. But I would say that if you are not already focused on this work or doing something, to just try something and then try again, because we really can't afford not to. So with that, I just want to thank you for your time. I'm looking forward to the discussion after this. Our burnout assessment work remains ongoing. So if you are interested in learning more information about how to do the COVID assessment, you can go to clinician.health, which is on the screen here. We also do mini-Z burnout assessments that can be found on our website as well. And with that, I will turn things back over to Brittany and look forward to your questions.
Thank you so much, Kira. That was both very informative and inspiring. Before we move to the Q&A, I wanted to run through some resources for our participants. For additional resources to support your physicians and care teams, please visit the AMA website. Today we mentioned many of the Steps Forward resources and interventions. The link to the Steps Forward website will be available on the recording page after the event, but we've also included a direct link in the chat box Peer support and PRRX was also mentioned, so that link is also available in the chat box right now as well. We encourage you to visit both of those sites to review the resources and tools discussed today. Next slide, please. Thank you. We thank you all for your time today and hope that you're able to join one of our next upcoming webinars. Our next one is actually scheduled for tomorrow, May 20th at 12 p.m. Central Time. This webinar will feature Dr. Catherine DeRoche, who will speak on adopting open notes. Next slide, please. Thank you. And then finally, for general questions or comments, please email the Steps Forward inbox. Again, that's stepsforward@ama-assn.org. Okay, now we're going to take some time to review our participant questions. Please feel free to put them in that Q&A box. Hello again, Kira. We already have a couple of questions in the queue, so we can go ahead and jump in. So Kira, in your presentation, you mentioned several organizational solutions and actions that can be implemented. This participant would like to know if you have any advice on gaining leadership buy-in for some of those organizational solutions and changes that you discussed.
Yeah, that's a great question. So I appreciate that question. Leadership buy-in is really important. Someone needs to be accountable for this work in order for it to be sustainable long-term. So, again, there's no silver bullet for gaining leadership buy-in either, at least in our experience at the AMA. But what I can say is that if you know or can figure out where your leadership's priorities are, the messaging around the need for resources around wellness can be adapted to wherever their priorities lie, because burnout impacts everything in the healthcare system. So if your leaders care about costs, we know from research that burnout is costly. From turnover, it costs almost $1 million or more to replace a physician who leaves the organization. So there's a major cost to burnout if that's what we care about. We actually have a calculator on our Steps Forward website, and that might be something we can put in the chat as well, where organizations can kind of plug and play numbers based on the number of physicians you have at your organization. If you know your annual kind of turnover rate and what that's costing your organization, especially due to burnout, if you've done a burnout assessment and know how many people in your organization are experiencing burnout. If your leaders care about quality and safety, there is obviously research to show the negative impact that burnout has or can have on patient care. So, ultimately, I think we have to understand the mental models that our leaders are working within, so that we can adjust our messages accordingly, so that it's really being seen as an investment rather than a cost. So if they can put resources towards, a well-being committee, hiring a chief wellness officer, what have you, that is an investment, it's not a cost. And then lastly, I would just add, use data. We see time and time again organizations who come to us survey for the first time. This is the first time that they're starting to understand how many people in their organization are actually experiencing burnout. And that data can be a really strong starting point for a conversation with leadership when you can show them what people are actually experiencing and the possibility that they may leave an organization and hopefully nothing worse than that, but data can be a really strong starting point as well if you have it.
Thank you, Kira. That's really helpful. Our team already put a link to the cost calculator in the chat, so you can use that direct link to access it. Okay, so for our next question, today we spoke a lot about organizational resiliency. So this next question is going to shift us over to individual resiliency. This participant would like to know how the AMA thinks about individual resiliency and its importance in this overall work. But then additionally, they would like to know if COVID has changed the way that the AMA thinks about the role of individual resiliency.
Yeah, also a really good question. So I would say our thinking is changing a little bit, but for the most part, we have focused a lot of our work at the AMA less on individual resiliency and more on the systemic drivers of burnout in the way that systems and organizations impact burnout within their organization. So I would never suggest that individual resiliency is not important. We have data to show that things like mindfulness do support individual resiliency, and that is one facet of this work. But we also know from research that was published recently that physicians are not lacking in resiliency. In fact, physicians have higher resiliency than others in different fields. So this is not a lack of resiliency, and sometimes the messaging around individual resiliency can make it seem like organizations are putting the blame on individuals and having them do one more thing and think about one more thing. So we center our work around the Stanford wellness model. That may be something we can also link to or send in follow-up, but I think maybe many of you might be familiar with this, where the drivers of burnout are related to three things. Individual resiliency is one of them, culture of wellness is one of them, and practice efficiencies. And most of our work is centered around the culture of wellness, so really, again, making wellness an institutional value, a core institutional value, and having resources to support that. And then thinking about things like practice efficiency, so where physicians are spending their time, how to streamline workflows, implement things like team-based care. So that's still where our mental model is at the AMA around resiliency, and yet, as I've shared during the presentation, with small things like concierge type services, having food available, et cetera, was really important at the beginning of the pandemic. Those small things and just making it one less thing for people to think about was really important. And it wasn't saying, hey, you need to go do mindfulness, you need to do better, you as a physician or whoever you are. But really that was the organization stepping up to say, you know, we've got you right now. We're going to take one less thing off your plate. So there's certainly a role for it.
Yeah, thank you, Kira. I'm going to backtrack us a little bit to the previous question on buy-in, and where we discussed a bit, where we talked a bit about the cost calculator. This participant would like to know if the cost calculator only works for physicians or if it could be applicable to other clinicians like APPs.
Yeah, that's a good question. I don't know that I'm the best person to answer that. That might be something we follow up with you on. I know that the calculator we developed was based off of research that was published in JAMA that was largely focused on physicians. So I'm not sure that it's entirely applicable to APPs, but Britt, maybe that's something we can follow up on.
Yeah, we definitely have people who helped develop and implement the cost calculator available to us. So we'd be happy to follow up with a more thorough response afterwards. Okay, so shifting us a bit, I'm going to move over to the chat. We do have a question in there. This participant would like to know if the survey results presented today have been published or where they can find them.
Also a really good question. So we obviously have a ton of data that we've been sifting through. We have published 2 papers, and we can either include those in the chat or in follow-up. We have a paper that was published in Mayo Clinic Proceedings earlier this year, and we actually just released a paper in the Lancet this week. Actually, it was published on Sunday. That second paper in the Lancet was looking at our healthcare workers outside of physicians, so it looked at a 20,000 person data set. We have not yet made available the full report that we have with over 60,000 responses. We are still figuring out our strategy for doing that. We have a couple of publications in the pipeline, but our hope is that we can create at least some kind of summary of the data that we shared today so that organizations can use that. And the other thing I would share is that organizations that surveyed with us using the COVID survey did receive a report of the national data so that they could compare their responses to what we were seeing nationally. Again, just to prop up those conversations they were having with leadership around resources to say, hey, maybe we're doing better in this area compared to the national data that AMA has, but we're doing worse over here. And so this is where we're going to focus our strategy for the next year, 18 months, what have you. So that is something we provided to the groups, but we're still working on how we can share those data more broadly with the public.
Thank you, Kira. We've mentioned a lot of resources today, so links to those papers as well as all of the resources will be consolidated and provided on our archive page. We will have our team provide a link to that archive page here so you know directly where to access them afterwards. Okay, it looks like we have one more question in the queue, so if there are more questions, I encourage you to please put them in now. Let's see here. This next question looks like it's coming from a physician in a smaller practice. They would like to know how a smaller practice can become involved in the assessment work.
Yeah, so we've been doing the assessment work for a while. We queue systems right now, and there's nothing that says that small practices can't come in and do assessments. So if you are from a smaller practice, and I'm not sure how you're defining smaller practice, but if you're from a smaller practice and are interested in doing an assessment, certainly reach out. We have information on our website, or you can reach out to me directly, and I'd be happy to talk with you about those options. I will say that we ask for organizations to have at least an N of 30 in their surveys from a statistical perspective in reviewing the data. So assuming you have at least 30 physicians or APPs that could complete the survey, we'd be happy to talk with you about doing that assessment with you. And then I would say if you are much smaller than that, which is okay, we have a lot of groups that will then just focus on things like focus groups, and again, just doing rounding and kind of hearing from people rather than collecting sort of quantitative data. And there are a lot of resources on the Steps Forward website specifically for smaller practices. So I would encourage you to check out the Steps Forward website as well.
Thank you, Kira. This has all been so helpful. We do have another question in the queue. So it says, this question asks, with the availability of mental health providers decreasing as a result of the pandemic and the stigma associated, what about coaching as an alternative for individual intervention?
Yeah, I think that's a good question. I don't know that I'm the best person to answer that. We have seen groups do some coaching. And again, I think this is where peer support has been so important. So for groups that couldn't necessarily have a mental health provider on site to do individualized therapy or what have you, having peer support available was important, will continue to be important. So that, I'm not sure if that's what you're referring to when you talk about coaching. Coaching may be more like mentoring, which of course a lot of groups have done in a pre-COVID time as well. I think all of those are viable options, and organizations should be thinking about what is available to them. And I think coaching or peer support, are really viable options for that.
Thank you, Kira. Again, a link to the peer support resource that we mentioned is up in the chat. It's the PeerRx Med website. I'm going to go back to discuss more of the findings and then interventions. Kira, this next question asks, based on your findings, what interventions do you think will help over the next 2 years during the pandemic recovery phase?
Yeah. My gut was like, just do anything, because I feel like a lot of organizations may not be doing anything. And I would say now is the time to start and try something. But given what we know from SARS, for example, around mental health is probably going to continue to be something we need to be paying very close attention to. So what kind of mental health supports are available, and also reducing stigma in healthcare. There is still so much stigma around help seeking, and just talking about mental health. Some of that comes from our licensure laws, which of course, that's an advocacy related item that we're thinking about at the AMA, and I know a lot of other groups are as well, but just trying to reduce stigma so that people feel that they can seek help, and that there are resources to seek help. More broadly though, even in a pre-COVID world, we have major issues around our workflows, especially in primary care. And, we know that for every, 1 hour that a primary care physician spends with a patient, they spend 2 hours on documenting. And so that's a huge cause of burnout. So we're kind of rethinking about how we can redesign care so that our workflows make more sense, that we can train up support staff so that physicians feel like they can operate at the top of their license, and ultimately the whole care team can thrive from that. So I don't have, again, the silver bullet on that. I wish I did. I wish we all did. But we do have some interventions on our Steps Forward website, specifically around primary care for things like team-based care with in-room support, which we've seen some success in our data with. And really, but I think really focusing on culture, the culture within your organization, what the messaging is like around wellness, who's saying those messages, what kind of investment there is, and again, just kind of reducing stigma around that. So I know that probably doesn't answer your question in its totality, because you may be looking for specific interventions, but I do think this culture piece and making wellness a core institutional value, which I do think starts with data and measuring and having that part of the conversation is a really good starting point.
Yeah, Thank you, Kira. I think all of those interventions are certainly helpful. Looks like we don't have any more questions in the queue, but our participants can certainly email follow-up questions after the event. Again, that Steps Forward email address is stepsforward@ama-assn.org. With that said, I think we can go ahead and wrap up today's session. Kira, first and foremost, thank you so much for your time and expertise today. It's so appreciated. To our participants, thank you again for joining us. We hope to see you again soon, perhaps in tomorrow's webinar. Have a wonderful rest of the day, rest of the week.
Yeah, Britt, can I just say one last thing?
Absolutely.
I would say, humbly, we are still learning from all of you. So if you are doing this work, please don't be a stranger. We would love to hear from you. Again, we're learning with you. We don't have all the answers, but we're hoping that together we can find the answers. So Britt, thanks for the opportunity to chat with everyone today. And I'll hand things back over to you.
Thank you, Kira. Thank you for that last important message. Really appreciate it. Again, please reach out to us for both questions and comments. We appreciate you. We appreciate your participation. Thank you so much, Kira. Take care.